So the title of the talk is BEST-CLI in BASIL. I told PK that PK was in Singapore recently. I gave him a talk on a medical talk. I think this is his revenge for me giving him a medical talk. This is my disclosure. The only disclosure I have that's relevant is a vascular surgeon to train in open surgery, but ended up doing endo. I've been conflicted all my life. Okay, so this was a recent publication on a grand summary of what the BEST-CLI study is compared to the BASIL-2. BEST-CLI is 1,800 participants. The major differences were that the endpoint was major adverse limb event, or MALI, or death. They had two cohorts. The first cohort had a good vein. The second cohort had no good vein, so ended up with prosthesis most of the time. If you look at, there was a difference in terms of the endpoint in the first cohort, but not the second cohort. The BASIL-2 was a pretty much smaller study in the UK and some places in Europe, but this is essentially an infrapopliteal study compared to BEST-CLI. BEST-CLI was a mixed, anything below the groin, but BASIL-2 was essentially an infrapopliteal study, and BASIL-2 actually, the endpoint was a conventional major amputation or death on AFS. Not pretty different from major adverse limb event. We'll dwell into this a little bit later on. Essentially, if you look at the patients, they were slightly different. The BASIL-2 patients were older with more cardiac problems. Many of them were previous re-intervention. BEST-CLI was a major adverse limb event, which included conversion to a bypass, and then mortality as well, but BASIL-2 was amputation-free survival. BEST-CLI was treated mainly by vascular surgeons, and BASIL-2 was treated by interventional radiologists. The conclusions, as I mentioned before, in the BEST-CLI, that you bypass with fewer major amputations and re-intervention than EVT, but in BASIL-2 was that EVT had a lower AFS compared to BEST-CLI. So again, just into the details, 32% reduction in MALI, driven significantly by more major re-interventions in the EVT arm, and EVT experienced 2 times the number of major re-interventions during the follow-up period, and not much difference in terms of the death or myocardial death. And BEST-CLI basically confirmed that both therapies work with lower rates of major amputation. Bypass should be a viable option in patients with an appropriate saphenous vein graft. BASIL-2 affirmed that patients with critical limb ischemia with infrapopliteal disease who required some form of revascularization below the knee, if you had a vein graft and you did a bypass, EVT was superior compared to vein bypass if you looked at the endpoints of amputation-free survival and quality of life. So what did I learn? Both were so complex studies, it took time just to revisit these. BASIL-2, as I mentioned, they were older, many more previous re-interventions, more cardiac comorbidities. Both studies had mostly men and white men in both studies, so not exactly representative of the population, at least in my practice. Definitely in my practice, because, in Asia, anyway. The anatomical patterns of disease in BEST-CLI, most of these were above the knee. If you look at the anatomical presentations, femoral popliteal, and only 30% were tibial only. 40% of the bypasses based on anatomical patterns were fem-pop, both above and below. But if you look at BASIL-2, all of the bypasses were below the knee. So the real question you need to ask, if you look at the studies, which kind of study accurately reflects the type of bypasses you would consider based on the average patient that comes through your practice? Is it a fem-pop or a below-knee bypass? Even if you look at the types of bypasses they did in endo failures, a majority of those, 40% of those, 47% of those in endo failures were bypasses as compared to those or in a similar group in both cohort 2 where they used prosthetic bypasses. So how often does it reflect? If you have an endo failure in your lab, how often is it due to an SFA problem and how often is it due to an endo problem, a BTK problem? Slides courtesy of Peter Schneider. If you look at the difference between the two, the technical success in the endo group was 85% only, and really and this was considered a failure of the primary endpoint, because if you had a technical failure, this was considered a failure and a loss. So the real question you need to ask is, compared to other trials which use CDTLR typically, is this considered a valid endpoint? Conversion to open surgery, in the trial, members of the local CLI team, one was credentialed for vascular surgery and one was credentialed for endo, had to agree if the patient was suitable for both techniques, and the decision to re-intervene was made by 2 members of the team. But we do know that some of the conversions to open surgery were made at a point of time during the endo failure in the OR, and consent was taken for both endo and open at the same time. So could the endo failures be handled by a more competent operator? Could there be a cooling off period where the patient would come off the table and then the endo specialist could have a good, another attempt at opening up this vessel, and this is potential for selection bias. Another thing is the appropriateness of the endpoint. This endpoint is a new endpoint. It's called Mali-free survival. Basically, it means the amputation above or a major re-intervention. Re-intervention was introduced as an endpoint, and the re-intervention included a new bypass graft or thrombectomy or thrombolysis, so and so forth. And in their publication, they said that the endpoint introduction of a major re-intervention of the limb was a more sensitive marker of quality of life, and hence was chosen in the study design as a primary endpoint. And the avoidance of major interventions, according to the authors, would significantly impact the quality of life. However, subsequent to the publication of the BEST-CLI study, they did do a subsequent study that realized that there was actually no significant difference in the quality of life between the open surgical and endovascular arms in either cohort. So, which really calls the question, is Mali still relevant when there's actually no quality of life? Mali was chosen because they thought that it would be a very sensitive difference in the quality of life, but a separate quality of life analysis did not show this. In terms of credentialing and competency, for the endo credentialing, you need to do at least 12 below the knee interventions in the last 2 years, and open at least 10 surgical bypass in the last 2 years. So the real question is this the appropriate level of competency in your practice? If your residents be doing just 12, or would attendings just be doing 12 below the knee interventions in 2 years? Is it applicable in daily practice? This is a study run by our Japanese friends. This is Dr. Hata and Ida. They look at how BEST-CLI is applicable in their real CLTI practice. So they look at their data, and they found that 87% of their patients had standard surgical risk, so could undergo a bypass, and 76% of them had a distal bypass landing zone, which is a P1, and 46% had a GSV diameter of more than 3. But if you combine it, if you can see, so 87% of them are fit, and in the second risk factor, they have a distal landing zone, that drops to 66%, and for those with a saphenous vein graft, that further drops to 33%. And based on this 33%, and they had a look at the Wi-Fi and GLASS classification, they found that only 8.8% of these patients would be suitable for bypass surgery. Only 8.8% met the global vascular guidelines-based bypass preferred conditions. So in their practice of 300 over patients assayed over 1 to 2 years, it only showed that 8% of them were appropriate for bypass surgery. How about therapy in BASIL-2? You look at BASIL-2, and most of it was balloon angioplasty. Arthrectomy wasn't used. Bailout stenting was not used. Is this reflective of the kind of work you do in your daily practice? Dialysis population is low, so disease pattern is largely bad disease compared to sad disease. Finally, medical therapy could be improved. Both trials showed that patients with critical limb ischemia had high mortality rates regardless of whatever intervention they did. As you can see, 35% of these patients, 25% in cohort 2, and 49% of these patients in BASIL-2, and a third of these patients were not taking optimal guideline-based medical therapy. So in summary, randomized controlled trials can only answer the questions in a very select group. Treatment offered to the patient must take into account the needs and the operator experience in the center, and formal data sharing between the BASIL-2 and BEST-CLI would give us new data. Thank you very much for your attention.